The next session is on end of life care in Indian scenario. Uh, with us, Dr. Shiv Kumar Iyer, sir. So he's a very well-known person across India, past president of ISCCM, national president. So sir is well published everywhere. So sir doesn't require any introduction from my side. So none other than Shiv Kumar sir who can speak on this topic. It's a very interesting and sensational topic. That's end of life care, everybody knows, but in the Indian context, so there are so much variation in the laws, regulations, which keep on changing. So let's listen from our expert Shiv Kumar sir. Sir, you are welcome to the session.
Good evening, delegates at CRITIC 2021 and the organizing team. Thank you so much for inviting me to speak on this very important topic. So what I'm going to do is to take you through the end of life care in India, the current status. And, current status, I'm going to go a little back in history from 2014 so that you have a background as to what I'm going to speak today. So in 2014, there was this Supreme Court notice which was issued to all states and union territories on a plea that they had received to legalize passive euthanasia. This plea was admitted 2005, and it was finally, the judgment was pronounced in 2018. So you can see that there is, in 2018, there's a Supreme Court judgment on common cause. So I'm going to start by describing this common cause judgment, because I think it has very important points, and it is absolutely relevant and pertinent for us at this point in time. Then, I will be talking about how we can think of implementing some of these points in the Supreme Court judgment using this FICCI Elicit guide. FICCI, as you know, is a Federation of the Indian Chamber for Commerce and Industry. So it's a very important and powerful body which includes many corporate hospitals as well. And Elicit stands for End of Life Care in India Task Force, which comprises the Indian Society of Critical Care Medicine, the Indian Association of Palliative Care, and the Indian Academy of Neurology. So three preeminent organizations which have a great stake in end of life care. And FICCI, of course, being a powerful body as it is, has come out with this guide for patients, administrators, and hospitals. So these are the things that I'm going to focus on, and I'm hopefully going to show you what we can do given the current status. And then finally, a little bit about the COVID-19 and are there any papers from India on this. So this is the judgment, and the Chief Justice of India himself, Chief Justice Deepak Mishra and Justice A.M. Khanwilkar, they pronounced this judgment in 2018 March. And the highlights were, we declare that an adult human being having mental capacity to take an informed decision has the right to refuse medical treatment, including withdrawal from life-saving devices. Before this right to refuse medical treatment, including withdrawal, was not there. And the Supreme Court confirmed through this judgment that we have this right to refuse medical treatment. So one can say that there is now legal sanction for withholding, withdrawing therapy. Though, sometimes the devil is in the details. So we're going to see what difficulties we may face in doing this. And the second important point of this judgment was that a person of competent mental faculty is entitled to execute an advance medical directive in accordance with safeguards referred to above. So we're going to see what these safeguards are and what the devil is in these details. So when we think of implementing, what the Supreme Court has said, that is, the advanced medical directive should be a written document which should clearly indicate the decision relating the circumstances in which withholding, withdrawing of medical treatment can be resorted to. Fair enough. The document should be signed by an executor in the presence of two attesting witnesses and countersigned by jurisdictional JMFC, Judicial Magistrate of First Class, so designated by the concerned district judge. The JMFC will have archival and dissemination responsibilities. They will preserve one copy in both paper and digital format. hand over one copy to the registry, inform the immediate family members about the existence of this document. One copy will be handed over to the competent design officer of the local authority, and one to the family physician if there is any. So you can see that they've put in a lot of safeguards in this, but nothing has happened after the 2018 judgment. So this JMFC, the instructions to the municipal corporation, the creation of this archival and dissemination mechanism is still not in place. Then finally, in the event of a terminal illness, the physician concerned must ascertain the genuineness and authenticity thereof from the jurisdictional JMC before acting on the same. So, this is very much in the realm of, only in the realm of possibility. It is still not completely vetted, though the Supreme Court direction is very clear. And then you can see what are the difficulties. So, person has to think of his wishes regarding ULC, has to consult the doctor, write the EMD with the help of doctor, name the executor, sign it in front of two witnesses, executor signs, then the JMFC signs, and then a digital repository of the AMD is created. And none of this, except maybe the first three maybe, have happened. Then, of course, once the AMD is prepared, how does one finally forego life support? That again is a lengthy procedure. So what the doctor is supposed to do is to confirm the presence or absence of an advanced medical directive, confirm its validity, the mechanisms for which do not exist at the moment. Then he has to constitute a local medical board within the hospital. After he does that, then he has to inform the collector. The collector then constitutes a regional medical board. The regional medical board visits the patient. Regional medical board informs judicial magistrate. Judicial magistrate visits the patient and authorizes the decision. And if the board refuses authorization, the High Court may be approved. So you can see that this lengthy and, in my mind, unnecessary procedure has made implementing this practically impossible. But be that as it may, we are well within our ethical and legal rights to practice end-of-life care, because the Supreme Court has very clearly said that the right to refuse treatment, the right to die with dignity, the right to prepare an advanced medical directive exists. So what should we do? I think what we have been doing so far till this 2018 judgment, we should continue to do. And for this, there is no better document than the FICCI Elicit pathway of 2019. Elicit and FICCI came together and have formed this pathway. I'll show it to you in a minute. Then there is an ICMR DNR document in the Indian Journal of Medical Research 2020. Dr. R.K. Mani is an author in this. And of course, he was instrumental in preparing this FICCI Elicit pathway with other members from IAPC and Indian Academy of Neurology, and of course, the members which included me. So now look at this pathway. You can see the first step, as always, is to accurately identify the terminal illness, the prognosis, and the inappropriateness or disproportionate nature of life-sustaining interventions. Once you've accurately identified this as an intensivist, then next thing is to establish consensus among all healthcare providers, including primary consultants. Once that is done, the competence of the patient needs to be determined. Now, many times in the ICU, the person will be incompetent because of the nature of illness, and perhaps he's on a ventilator, he's not able to speak, he's delirious. So there may be many reasons why he may be incompetent. If he is incompetent, then you need to check whether an AMD is available or AMD is not available. And like I said, currently, since AMDs are so difficult to prepare, people won't have AMDs, but they would have expressed their wishes. And if they have expressed their wishes, then what we should do is use their expressed wishes to work with the appointed healthcare proxy or next of kin. Now, many times there may not be an appointed healthcare proxy or an AMD, so we have to work with the next of kin. So that's the situation we are in at the moment. Of course, if the person is competent, then one has to talk to that patient, probably along with the family, do an honest disclosure of the terminal illness, prognosis, and the disproportionate nature or inappropriateness of life-sustaining interventions, or DNAR, as may be the case. Then use the model of shared decision-making with open and repeated discussions. And if there is no conflict, then you can implement a plan for withholding withdrawing therapy. You can use the pathway for this. And not only should we implement this pathway for withholding and withdrawing, but we should make sure that patient receives appropriate symptomatic care after withholding and withdrawing of life support, and the family receives after death care and bereavement care. This entire process should be subject to a review using the well-known principles of audit, and it should be improved as time goes on. If there is conflict, then you may need to use a conflict resolution process. The conflict resolution process will include taking second opinion. It may include setting up a hospital committee, which will help you to talk to the family as an independent hospital committee and help you to resolve the issue. And if there is no consensus after this between family and the treating team, sometimes the court may need to be approached. This is the ICMR document for Do Not Attempt Resuscitation 2020. Again, it is landmark because people believe that Do Not Resuscitate does not apply in India. And this document very nicely shows how you can implement a Do Not Resuscitate order. Be that as it may, there are still many barriers to implementing appropriate end-of-life care. There is fear of death and uncertainty in laypersons and doctors alike. There is a lack of awareness among doctors about the guidelines and the pathways. We have not been trained in communication skills, which will help us to communicate well with our families and patients. And there is this fear of law among doctors. I hope I have dealt with this fear of law, and I've given you some of the latest guidelines and pathways that you can use. Communication skills we need to build, and for this, we need to work on getting good communication skills workshops in the place. The way to overcome these barriers would be to understand patients' rights, understand our obligations as physicians, and prepare a hospital policy based on the NABH guidelines. So you can see patient rights, they've been put up here, and the right to refuse treatment, and the two of the recent Supreme Court judgments. Common cause, I've told you about that. And there is an international consensus on this as well, about patient rights to refuse treatment and die with dignity. Please remember, even though the word passive euthanasia is in common, it has nothing to do with euthanasia. Passive euthanasia is actually withholding, withdrawing therapy, whereas euthanasia is the active shortening of the dying process, and which is something which is not allowed in our country and is not legal as well. So we cannot actively shorten someone's dying process, which is euthanasia. Passive euthanasia is an oxymoron, a wrong term, and we should use withholding, withdrawing therapy instead. If you look at the physician's obligations, you can see that the physician needs to respect autonomy of the patient primarily. And this autonomy of patients or families, the physician should help them to exercise this by giving them an appropriate and accurate picture of beneficence versus non-maleficence, that is, benefit versus risk. Administrators' duties in hospitals should be to provide and have a hospital policy on end-of-life care, have a hospital EOLC committee, create the necessary infrastructure for providing EOLC and palliative care, ensure maintenance of records, and devise a mechanism to facilitate conflict restriction. Hospital EOLC committee can be some of these people. And even though most of our hospitals don't have a formal hospital EOLC committee, it would make sense to have a committee of this kind. These are some of the NABH standards from the 5th edition. This is Annexure 1 on the fact sheet on the end-of-life care. And NABH mandates that these standards be followed. During COVID-19, end-of-life care has become even more difficult, especially the communication part, because we've not been able to directly speak with family members. Most of them, we've had WhatsApp calls, WhatsApp video calls, or just phone calls. And face-to-face meetings have really disappeared. This article is an experiment which happened at the Manipal Hospital. Dr. Naveen Salins, you can see the corresponding author, prepared a development of implementation of palliative care in ICU. And this paper tells you how difficult it can be to implement appropriate end-of-life care and palliative care. So there was a low referral of serious and critical COVID-19 patients to palliative care specialists, and appropriate palliative or end-of-life care was not done in a majority of patients. So how can we improve this? What is the way forward? Of course, we need to clarify the 2018 Supreme Court judgment and get the process, the implementation process, to be simplified as much as possible. We should probably have an act from Parliament governing end-of-life care and palliative care. And for this, the Vidhi Legal Policy Group has prepared a draft bill on this, which is a model bill. One must look at it. Then hospitals should use the NABH annexure on ELC for setting up their hospital protocols. We need to increase awareness among doctors. And I think intensivists are an important part. We need to increase awareness in society. We need to bridge the gap in doctor-patient relationships and improve our communication skills. These are some of the useful resources. The first is the Supreme Court judgment. Second is the NABH annexure. Then we have this ICMR definitions for limiting life-sustaining therapy. This has clarified to a large extent all the terms that we use in end-of-life care. For example, passive euthanasia, that passive euthanasia term should not be used. Then there is this landmark paper, the End-of-Life Care Policy and Integrated Care Plan for the Dying, a joint position statement of the ISCCM and the IIPC. And then finally, there is this FICCI Illicit Guide for implementation of end-of-life care. I hope I have been clear, and I hope I have not exceeded my time too much. Thank you so much.